Hey everybody, we're getting to the heart of the matter here. We're going to be looking at the cardiovascular system, which is a very important system because it is the pump that pushes the life-giving substance of blood through the various nooks and crannies of your body. Okay, in essence, what the heart does, it's got two main jobs. It bridges the gap between the lungs and the body. Uh, Remember that the lungs are going to bring oxygen to your body. And then as your body makes energy, there's a byproduct. Literally think of it being like exhaust. And the byproduct or the exhaust is CO2, and that escapes in the lungs. So this is a very important function that's happening all the time. You're continually bringing in oxygen and getting rid of CO2. And the heart is the pump that drives the fluid to flow in between these two domains, the lungs and the body. So the pump will stand in the middle of this, and the way that it works is it receives the oxygen-rich blood from the lungs, and it receives it in the left side. And I've drawn the left side on the right to get you used to the fact that when you look at the front of an organ, it is the reverse. Like if I was holding my left hand in front of a classroom and looking at you, it would actually appear to be on your right side. Anytime you're looking at the front of something, the left is on your right perspective, and vice versa. And generally when we're looking at diagrams or models, we are looking at the front, and so it's a good practice, I think, to get used to that switch. So that's why I've drawn it on the opposite side here. Okay. Now the blood will come in through the top chamber. This is called the left atrium, and it will pass through a valve into the bottom chamber, which is called the left ventricle. And then from here, it will pump it out to the body. And when I say the body, I basically mean everything except the lungs. Okay, so this would be your head, your arms, your trunk, your legs, your torso. Okay, that blood is still oxygen rich because it hasn't undergone capillary exchange yet. It hasn't actually released or offloaded the oxygen. In all of the travelings through the arterial network, much of the oxygen is conserved, and so it makes it to the capillaries that are found throughout the body. Okay, on the distal side, or the other side of the capillary bed, then blood now is returning, and this blood is oxygen poor. And when I say oxygen rich and oxygen poor, I think there's a misconception that the arterial blood going to your body is full of oxygen, and the venous blood returning from your body has no oxygen in it. That isn't necessarily true. When I say oxygen rich, what I mean is that these red blood cells are close to 100% saturated. They're like 98% saturated probably. The oxygen poor blood is probably closer to maybe like 75% saturated. So it still has a lot of oxygen in it, even in the venous blood, the oxygen poor blood. Okay, now what would make most sense at this point is we have oxygen poor blood, and we need to go get more oxygen, so it would make sense that this would go straight back to the lungs to get that oxygen. And this is where a lot of students get tripped up. They generally think that the body, the venous blood collects and is brought to the lungs, and that is true, but it has to return back to the heart. The reason for it is that the heart pressurizes the blood, and then there's a pressure gradient that pushes the blood into the nooks and crannies of the body. But by the time we've gotten to the vast cross-sectional area of the capillary beds, much of that pressure gradient has dissipated, and so there isn't much pressure left, and it's usually a pressure gradient that drives the fluid to flow. And so there's actually a pretty low pressure causing the fluid to come back to the heart, and it wouldn't be enough pressure to send it to all the capillaries in the lungs, and again, because there's such a big vast network of tubing in the capillaries. So all that to say, the blood has to take another trip, another pass back to the heart in order to get to the lungs. So it's going to pass into the right atrium, and it's going to pass through a valve into the right ventricle, And then from here now it has to go. It's going to get repressurized. So we're gonna pump some pressure into the system, and that's going to be what allows the fluid to now pass through the vast capillary networks of the lungs. So we call it sort of like a figure-8 loop. You have oxygen-rich blood coming into the lungs, going to the body. Oxygen-poor blood coming back to the heart and then out to the lungs. Getting oxygen, now it's oxygen-rich, going to the heart, to the body, then back to the heart, then to the lungs, then to the heart and to the body, then back to the heart and to the lungs. It forms sort of a continuous figure-8. Now, we call these different circuits. So the circuit that goes from the heart to the lungs and back to the heart, so this circuit right here, this would be called the pulmonary circuit. Okay, the other one that goes from the heart to the body and back to the heart, we call that the systemic circuit, because it sends blood through your entire system, the whole arterial system. Okay, now another couple of things, or another thing to keep in mind here is that there is a difference between arteries and veins, and it's common that most people believe that veins carry oxygen-poor blood and arteries carry oxygen-rich blood, and that is often the case, but it's not the true convention. The true convention is this: an artery is any vessel that carries blood away from the heart, and a vein is any vessel that carries blood toward the heart. It doesn't matter if it's oxygen-rich or oxygen-poor. So, for example, the vessels that carry blood to the heart from the lungs, those are oxygen-rich. That's oxygen-rich blood in those veins. But they are called veins because they're going towards the heart. Or similarly, blood that's leaving the right side and going to the lungs, this is oxygen-poor blood, but because it's leaving the heart, we call it an artery. So the difference between artery and vein. The other thing, just an important thing to remember, is that the left side of the heart is going to send blood to the body, and the right side of the heart is going to send blood to the lungs. So you might speculate about which chamber you expect to have thicker muscle, which chamber has the more difficult job, the left ventricle or the right ventricle, and the answer would hands down be the left ventricle, because it has to send blood to your arms, your legs, your head, and your trunk. The right side only has to send blood to the lungs and back, and that is a very simple job compared to the left side's job. The lungs are only inches away from the heart, and so there's not nearly as much tubing that the right side has to send blood through. So the walls of the right ventricle are generally thinner. All right, now in reality, the heart's anatomy is more complicated than what I've drawn here. I use this just as a sort of illustration to get you thinking about the left and right side, the pulmonary and the systemic circuits. But the anatomy of the heart looks a little something more like this. Okay, and it's still mostly there, still the left and the right side, the atria and the ventricles, but they're arranged in a little bit of a different way. Okay, so let's go through some of this anatomy here. Here's the division between the left and the right side. So this would be the left side here, and this would be the right side here. This chamber, we said, was the right atrium, and this chamber here is the left atrium. The job of the atria is to make the ventricles work as efficiently as possible. So the left ventricle sitting right here, and the right ventricle right here. The ventricles are called the working pumps because they're the ones that are actually doing much of the work. The atria are called the priming pumps, because they are the ones that receive the blood and prime the ventricles. And earlier I told a story about me having atrial fibrillation, and that's a condition where the atria are not beating rhythmically. They have sort of a sporadic quiver rather than a nice uniform contraction. And so even when your atria are not working, your ventricles still do work, but they only fill about 70% their capacity when the atria are not involved. They will passively fill 70%. When the atria are working, it squeezes blood into the ventricles so that they are as full as they possibly can be before the contraction. Okay, so that's the first thing, is the chambers. Now there's a few valves in the heart. Most good pumps have valves, and the valves keep the blood from going backwards. The valves keep the blood going in the one direction. A pump would not be very good if it, the purpose of a pump is to pump blood from point A to point B. A pump would not be very good if the blood went from point A to point B and then back to point A again. So the valves help to prevent backwards flow of blood. And there's two different sets of valves. Here there are the AV valves, and the AV valves sit in between the atria and the ventricle. And the one on the left side is called the bicuspid valve because it has two cusps to it. This is also sometimes called the mitral valve because when you look at it, it looks sort of like the mitre, which is a hat that some official in the Catholic Church wears. It's got sort of these two little folds to it. Okay, so that's the bicuspid valve on the left side. On the right side is the tricuspid valve, and that one has three cusps to it. Okay, we also have these other sets of valves here. These are called the semilunar valves, and they govern the flow of blood out of the ventricle. So the one over here is called the pulmonary semilunar valve. And pulmonary, that word means anything pertaining to the lungs. And on the left side, we have it was called the aortic semilunar valve. And that governs flow coming out of this major vessel, the aorta. Okay. Other things to know about the heart are the great vessels. So the great vessels are the vessels that go into the heart and come out of the heart. So the main vessel that leaves the left side of the heart is this one here. This is called the aorta. And that's going to send blood to your whole body. Remember, the left side of the heart sends blood to the body. So there's three branches that come off of it. These are going to go up to your head and your arms. Then blood travels down and it goes across what's known as the aortic arch, and then now the descending aorta. And from here, that blood is going to go perfuse the trunk, so that would be like your torso and your abdominal cavity, and also the legs. Okay. Now, the right side, we said, was the one that collects the venous blood, so a lot of the blood that's coming from the body. And here we have some great vessels. We have what's known as the superior vena cava, and here we have the inferior vena cava. Okay, these words superior and inferior. Superior means above, and inferior means below. And the vena cava means it's the big vein. So you have the superior big vein and the inferior big vein. The inferior vena cava drains blood from the trunk and the legs. Whereas the superior vena cava, this will drain blood from the head and arms. So you can see you've got out of the left side of the heart, blood going to the head and arms and the trunk and the legs, and then into the right side, you have blood collecting from the trunk of the legs and the head and the arms. So this is going to perfuse a lot of the body. Okay, some of these other vessels then, the main vessel that leaves the right side of the heart, this is called the pulmonary trunk. And anytime you see the word trunk in vessels, it usually means a vessel that's about ready to split. And so this does in fact split into the pulmonary artery. And that would be, this would be the left pulmonary artery, and this would be the right pulmonary artery. And remember, pulmonary means lungs, okay? Then into the the left atrium, we have two sets of veins. These are together the pulmonary veins. And there's two of them. There's two left pulmonary veins, and there's two right pulmonary veins, and they all enter into the left atrium. All right, some other things that we could see here. This this region right here that separates the ventricles, that's called the interventricular septum. There are different layers to the heart. The top layer is called the epicardium, and it is just one cell thick. It's like a sheet that covers the whole heart. The muscular part of the heart, the muscular wall of the heart, is called the myocardium, and it is made out of cells which are called cardiomyocytes, or heart muscle cells. Okay, the inner layer of the heart is similar to the epicardium. It's called the endocardium. And it's actually the infolding of the endocardium that makes the valves. And what's interesting about that is that the endocardium is an epithelial tissue, so it doesn't actually have blood supply to it. And so these valves are not vascularized. There's no arteries running in the tissue of the valve here. And while you might think, well, what's the consequence of that? Because blood is always passing through it. Well, what's interesting is if bacteria can get onto these valves and they can coat themselves with a biofilm, they can actually stay hidden from the immune system. Even though there's blood constantly passing through, and that blood has antibodies, that are designed to seek out and destroy bacteria, if the bacteria coat themselves and hide themselves, there is no blood supply on these valves. So there can sometimes be a condition known as endocarditis, which is an infection of the heart valves, and that can also be a case when you have synthetic valves that are applied. Some people get pig valves, or synthetic valves, mechanical valves put into their heart if their valves get leaky, and that is something that can happen as we age. If a valve is leaky, what can happen is that blood can squeeze backwards through it, and that's called a heart murmur, because you can actually hear it on a stethoscope. You can hear this little whooshing noise in between the heart sounds. Okay, speaking of heart sounds, when you take a stethoscope and you listen to somebody's heart and you hear the bum 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 bum, what you're actually hearing is the valves. So we call it the lub dub, lub dub. The lub, the first sound, is the closing of the AV valves on either side, and then the second sound, the dub, is the closing of the semilunar valves. And so what happens is the atria contract first, they push blood through, and then the valve shuts. And then the ventricles contract and they push blood through, and then the valve shuts. So you hear the dum 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 dum. And in a heart murmur, if the valve doesn't seal properly, the blood will sort of whoosh out backwards. It's called regurgitation, or sometimes they call it a heart valve prolapse, because the valve is hyperextended, and you can hear the whooshing sound, and that sound that you hear is called a heart murmur. All right, so for the exam, could you label these different parts, the valves, the great vessels, the chambers? That's sort of step one on your quest. And could you tell me where blood is going to out of these vessels? That's your first hurdle to jump in this chapter. Okay, now this is what a heart looks like when it's not just a sketch. Here are the atria. And the atria have these little pouches that they have, which are called auricles. And then you have the myocardium here, the muscular part of the heart. And the heart is interesting because it has its own intrinsic circulatory system. You know, the heart perfuses blood to your whole body, but the heart itself is a highly active muscle that needs a lot of blood flow. So it has its own network of vessels to perfuse itself or give itself blood. And this is called the coronary vessel system. And how it works is right out of the aorta, so this is the aorta here, blood will leave the aortic valve on its way to the body. As soon as blood passes through, there's literally a bolus of blood that's ejected out of the left ventricle. And anything downstream from here, remember that this tube, the aorta, is connected to thousands of miles of tubing through which blood has to pass through. So any blood that leaves the ventricle, it has to push a whole bunch of blood down many linear feet, or literally linear miles of tubing. And anytime you push fluid through the tube, there's friction there, and so the longer the tube, the harder it is for the fluid to flow. So the heart has to push pretty forcefully blood to get out of this tube. And as soon as the heart relaxes, that blood wants to push back, actually push backwards. We call this the afterload pressure. And as the chamber of the heart is relaxed, it's the backwards push on the heart, or the afterload pressure, that forces fluid through the coronary vessels. And so you've got two branches. These are the first two branches off of the aorta. There's a question that somebody could ask you, what are the first two branches off of the aorta? And the answer is always the left and the right coronary artery. They're just downstream, just above the valve. And when the heart relaxes, blood is forced backwards. It's called retrograde, backwards through the coronary vasculature. And you have the left coronary artery and the right coronary artery, and they will perfuse the myocardium. What's interesting, and this is sort of some of the research I did at the U, if you can take a heart and remove it from an organism, you can cut the aorta, just like we've seen here, and you can put a tube inside of it, a little cannula in there, suture the aorta onto that cannula, and continuously force retrogradely a oxygenated physiological salt solution to feed the heart. And if you do that, you can basically keep the heart alive and working outside of the body. It's called Langendorf retrograde perfusion, and that's what I used to do on murine hearts when I worked at the U of M. This is sort of an interesting video that shows this. This is a little mouse heart, and you can see that I've got the heart. It's attached to this little cannula, and what I'm doing here is I've actually removed the left atrium, and I'm trying to put, as the heart is beating and it's being perfused with this continuous backwards flow of oxygenated salt solution through the coronary vessels, now I can actually put a balloon, a deflated balloon, in the left ventricle, and then that is hooked up to a pressure transducer that will give me a pressure readout of the pressure in the heart. You can actually assess the function of the ventricle on something as small as a mouse heart. So pretty cool technique that involves that whole process of perfusing the coronary vessels to keep the heart alive. Okay, now a major clinical application here, myocardial infarction and coronary bypass. what can happen is the coronary vessels can get blocked, and that's called an infarct. Anytime there's a blockage of the vessel, it's called an infarct, and so a myocardial infarction would be a blockage of the coronary vessels. That can be a partial block, or it can be a full block, and it can be, generally what causes the blockage are these little fatty plaques that get put in there. And if it's just a partial block, the patient might feel some chest pain. If it's a full block, then that's when the ventricles will stop beating, and that's called ventricular fibrillation, and that's when you have to get out the defibrillators. That's a pretty severe event. That's cardiac arrest. So before that happens, if somebody's feeling really tired and they're feeling pain in their chest, they might want to get checked out for a blockage in the vessels. And if the vessel is blocked, there's a couple things that can be done. One, they can go in and they can take a little catheter, put it in through your subclavian artery, I believe, or vein. I think subclavian artery. They bring the catheter in, and they have a little balloon here that actually blows up the occlusion, opens it up, and then they can insert a little mesh stent in there to keep the vessel open. Another thing that can be done is a bypass. So they can actually take, let's say there was a blockage here, they can take a vessel and they can suture it in and bypass the blocked part. So coronary bypass, and I'm not really sure why one would be used over another. They can take these vessels from different parts of the body. If it's the left anterior descending, on the left side of the heart, they want a little bit of a stronger vessel, and so they'll use an artery, usually the mammary artery. If it's on the right side, they might use something from the saphenous vein, the great saphenous vein, which is the big long vein that runs down your leg, and they can actually suture it in there and just bypass the blocked area altogether. One of the most common places, or maybe I shouldn't say common, but one of the most severe places for an infarct would be in this vessel here, which is called the left anterior descending coronary artery, because it comes off of the left coronary artery. And they sometimes call that the grim name, the widowmaker, because this is the one that is the most severe. If that one gets blocked, it will cause the most damage, because that is the one that's perfusing much of the left ventricle. Okay, let's talk about what makes the heart tick. This is the heart's electrical conductance system. The heart has its own way of generating pulses. So even if you take it outside of the nervous system, if you remove it from the central nervous system, it will still work. The central nervous system can turn up and down the pace of the heart, but the heart has its own, it generates its own pulses. So let's talk a little bit about this system. Okay, it all starts with these two nodes, and a node is basically a collection of cells that exhibit what's known as automaticity, meaning they can generate their own electrical pulse at a steady rate. Okay, the two places where there's a collection of cells that can do this are right here. There's a collection of those cells here, and there's a collection of those cells here. So the one that's more superior or higher up on the heart is called the SA node. And then sitting right in between the atrium and the ventricle would be the AV node, which literally stands for atrioventricular. Now, the SA node will generate electrical impulses at about 80 to 100 times per minute. The AV node is more like 40 to 60 times per minute. And so what happens is a pulse is generated and it travels down what are called the internodal pathways. So these are called conducting cells of the heart. Most of the cardiomyocytes are contractile cells, but there are some conducting cells in there that will carry the electrical impulse. And so you have the internodal pathways. Those are the ones that exist between the two nodes. Okay, also the signal gets brought over to the left side of the heart via Bachmann's bundle. So when the SA node does fire, it will spread that impulse to cause contraction in the right side of the heart and the left side of the heart, mostly simultaneously. The left and the right atria contract uniformly at about the same time. Okay, now what generally happens is, even though the AV node beats at 40 to 60 times per minute, a pretty standard resting heart rate would be closer to like 80 times per minute. And so this is called the pacemaker because it sets the pace of the heart. The AV node is a slower rate. Well, every time the SA node fires an impulse, it actually jolts or sparks the AV node as well. So even though it's going to normally depolarize or issue an electrical signal at a slower rate, it's constantly being hijacked by the SA node so that it matches or synchronizes the rate of the SA node. So that even though there are two nodes that could potentially generate the pulses, the SA node is called the pacemaker. It sets the pace of the heart. Your pace of your heart is generally not 40 beats per minute. It's usually closer to 80 beats per minute. Now this can change. There are sympathetic and parasympathetic nerves that innervate the heart, and with a parasympathetic signal, it will slow down the heart rate. With a sympathetic signal, it will raise the heart rate. So the heart rate can be changed with nervous innervations here of the SA near the SA node, but in its own right, it would beat at 80 to 100 times per minute. Now, generally, a resting heart rate is slightly less than 80, and that's to do with the fact that at rest, we normally have a little parasympathetic tone, meaning your nervous system is normally slowing your heart rate down a little bit. But if you were to remove it from the body, it would jump back up to 80 to 100 times per minute. All right, now speaking of pacemakers, if you have any trouble with your heart, they can go in and insert a pacemaker, which is a little electric device that has electrodes that actually shock, for lack of a better word, the SA node. And the lead, they go in generally through your your right subclavian artery, down, through your arm, down in through the inferior vena cava, and then they insert it here. And they'll leave the lead in here. So there'll literally be a wire that just is going to sit in your vena cava, and it will get covered with scar tissue. And then that lead gets connected to a battery that's put on the chest, just subcutaneously, right underneath the skin, generally right by the pectoral muscle. And that battery will literally, shock the heart into a rhythm. There's a company called Medtronic that makes a lot of those pacemakers, and they are a pioneer in that domain, because they literally, working with some researchers at the U of M, literally the pacemaker was invented. The battery-operated pacemaker was first tried and successfully worked at a lab in the U of M. So a really cool history there in terms of the medical devices history, the University of Minnesota. You can literally go, the Visible Heart Lab at the U of M. I used to volunteer at that lab, and they still do a lot of work with Medtronic and other medical device companies, and they do a lot of work with working hearts that have been removed from the body and studied. But okay, in either case, after we travel to the AV node, now it's going to travel down what's called the bundle of His, or the AV bundle. And then it's going to go down the bundle branches left and right, and then these are going to then pass into the Purkinje fibers, and it's the Purkinje fibers that are going to innervate the myocardium of the ventricles. So the Purkinje fibers really are what's sending the signal to the bulk of the muscle here. And here you can actually see in this diagram a really nice illustration of the fact that there's a lot more muscle on the left side of the heart than there is on the right side. You can see the exterior wall here pretty thin compared to the exterior wall, again because the left ventricle has to send blood to your entire body. And here you can actually see too also a better view of what the valves look like. They usually have these little strings on them called chordae tendineae, and they're attached to these papillary muscles that contract to set the tension of them so that they seal properly. Okay. Now there's a little bit of a delay here between the pulse leaving the AV valve, or sorry, the AV node, and then traveling to the Purkinje fibers. It's about 100 milliseconds, so a tenth of a second. And that delay is really important. That delay is what allows your atria to contract, there to be a pause, and then slightly after that pause, the ventricles contract. If all of your chambers contracted at the same time, it would be bad. your heart would not work very well. What you want is the atria to contract first. They will squeeze blood into the ventricles, get them as full as possible, and that does take a little bit of time. It takes just shy of 100 milliseconds, or a tenth of a second. You want that blood to get all the way packed and that whole contraction to occur, and then the heart, the atria to relax. And now after they're relaxed and they've done your job, then you want the ventricles to contract. And so the delay is important, and good design here. As the signal travels through the bundle of His and the bundle branches, it allows some time for that to happen. We call this the cardiac cycle. And the atria contract first. We call that atrial systole. Then the atria relax. We call that atrial diastole. And then shortly after that, we have ventricular systole, or contraction. And then after that, we have ventricular diastole. And it's a little bit more complicated than this, but for this class, you can just know the atria contract, and then shortly after that, the ventricles contract. Contraction means systole, relaxation means diastole. Okay, now these events of the cardiac cycle, atrial systole and diastole, and ventricular systole and diastole, we can measure those on what's known as an ECG. ECG stands for electrocardiogram, or if you're German, EKG, electrocardiogram, but it's spelled with a K. And here's a sample of what an ECG traceout looks like. So if you've ever been in a hospital and you've seen the little green monitor that's going beep, 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 that is the ECG machine, and it's creating a trace of the heart. And you can go into the clinic and get your leads attached to your heart. I just actually had this done not too long ago. I was having some heart trouble, and so they'll attach all these leads. This can sometimes be like a 3-lead, or sometimes more like a 10 lead. What we see here is a 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 lead setup. But what they'll do is they'll measure the electrical activity of the heart. The different leads are like different cameras that sort of give you a better view of the specific pathways of electrical activity in the heart. But a standard traceout looks something like this. You would have a little bump, a P wave, and then you'd have a big spike, which is called the QRS complex, and then you would have another bump, the T wave. And these little features represent different things. The P wave represents atrial systole. The QRS complex, this represents ventricular systole. The T wave represents ventricular diastole. Now you might ask, where does atrial diastole occur? And that actually happens about somewhere here in this, right before and during while the ventricles are contracting. So that event sort of gets lost in the QRS complex. People, cardiologists will look at an ECG, and it's usually printed on grid paper, and each box refers to a certain amount of time, and so you can actually measure how much time it takes in between these different events. And there are different parts to it, like there's the PQ segment, that'd be the time in between the P wave and the QRS complex. There's the ST segment, that'd be the time in between the QRS complex and the T wave. And if there's any abnormalities in those, it can suggest different heart issues. Or there's the PQ intervals and the QT intervals. I won't ask that you know the segments or the intervals, but you do want to know P wave, QRS complex, T wave. And based upon any abnormalities, they can tell the clinician a little bit about an arrhythmia. So an arrhythmia would be any abnormal heart rhythm, and there's a few that are possible. Here are some common ones. Of all of the arrhythmias, these are the ones that are more common that we would see in the clinic. And I want you to be able to recognize at least these. If I put these on an exam, could you recognize them? So let's talk a little bit about them. This one here, what we're seeing, okay, here's a P wave, here's a QRS complex, here's a T wave, here's a P wave, here's a QRS complex, here's a T wave, P wave, QRS complex, T wave. Those are all very normal, but what we're seeing occasionally is a P wave right here and right here, which doesn't lead to a QRS. Normally, always, a P wave should be followed shortly thereafter by a QRS complex. In other words, the atria contract, and shortly after, the ventricles contract. Here we have the atria contracting, and then there's nothing happening, and then the atria contract again, and then the heart cycle occurs, cardiac cycle occurs. That's called a heart block, and what it is it's something going wrong with the bundle branch right here. That you're having the atria contracting, but then when the signal is trying to make its way down to the ventricles, it gets lost, and only occasionally. It's only a partial blockage of that electrical impulse. So that would be called a second degree heart block. A third degree heart block looks something more like this, where almost every cycle you have a P wave that's not leading to a nice QRS following. Okay, so like here we have a P wave, nothing happening, and then another P wave, and then a QRS. Here we have a P wave, and then nothing happening, and then kind of like a deranged P wave, and then a QRS. So every beat there'd be it'd be sluggish. We are getting a QRS complex here, but it's really delayed. Normally you should have a P wave, and then very quickly thereafter the QRS complex. Here we're having P wave with these big PQ intervals here, or segments. So it's highly abnormal. Okay, that'd be a more third degree block, meaning the bundle branch is for the most part severely blocked. Other things that we could see here, this is what atrial fibrillation would look like. This is what I had when I was on the ambulance going on my way to San Jose in Costa Rica. We're seeing no P wave here. There's just a quivering, a frenzy of electrical activity happening. We're seeing QRS complexes, But remember, the pacemaker, the SA node, is in the atria. So when the atria are quivering, it can lead to a rhythm that isn't steady. So the contractions of the ventricles are very sporadic here. This is, you're seeing it's bump, 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 bump. That would be atrial fibrillation. And the heart is still working here. There's still blood getting to the body. The ventricles can fill to 70% full without the atria. But let me tell you, it's highly uncomfortable, and you can feel your heart. Feels like it's bouncing all over on a trampoline. Okay, tachycardia is when you have a very fast heart rate. And so you can see there's not a nice, this is usually, this part right here in the ECG is usually what changes when a heart rate's getting fast or slower. This is the relaxation period. In between the relaxation of the ventricles and the contraction of the atria. That's most often what changes, gets shortened when a heart rate increases, or it gets lengthened when a heart rate decreases. And here we have almost no pause here, no relaxation period. As soon as the heart contracts, it jumps right back into another contraction. And there would be probably P waves in here, but they're really hard to see because the heart is beating so fast. Okay, ventricular fibrillation is cardiac arrest. And this is much more problematic than atrial fibrillation. When we have cardiac arrest, this is where the heart has stopped beating. You have to get out the defibrillators. Those are those little paddles, and shock the heart to try and get back into a normal rhythm. So ventricular fibrillation, the ventricles are quivering now. There's no uniform contraction of the ventricles. Okay, as we're talking about heart rate, I'd be remiss if we didn't bring up a really pretty interesting story that involves a guy named Otto Louis. And Otto Louis was I believe, I forget now, but I believe either German or Austrian scientist. And he was studying what it is that causes the heart rate to change. So they knew that the heart could change its rate. They knew that if they stimulated the vagus nerve, it would cause the heart rate to decrease. The vagus nerve is a major parasympathetic nerve that goes to many different organs in your body. And so when your body is telling itself to relax, it will send impulses out of the vagus nerve, and that will cause your organs everywhere to sort of rest and relax. And for the heart, that means a decrease in heart rate and also a decrease in how strong or forceful it's beating. So they knew back in in the late 1800s that you can stimulate the vagus nerve and it will cause the heart rate to decrease. What they didn't know was, is that signal getting to the heart, is that an electrical signal or is that a chemical signal? They just called it the vagus stuff. There's something that's causing the heart rate to decrease. And so Otto Louis, he was working on this, and he couldn't figure out what to do or how to come up with the answer to the solution. So he's dreaming one night, and the dream comes to him of the experiment he has to do to prove the riddle, to answer the quandary. And so he falls back asleep, and he wakes up, or he wakes up and he scribbles all of his notes into his journal, and then he falls back asleep. Well, when he wakes up in the morning, he doesn't have the same clarity he had during the night, and he reads his journal, and all appears to be his scribbles. He can't make sense of it, and so he isn't really sure what he needs to do. It was mostly nonsense. So now he's frustrated because he thought he had this great epiphany. He thought he knew how to solve the riddle, and he couldn't figure it out. A few nights later, he has the same dream, and so he gets up and he doesn't delay. He goes right into the lab, performs the experiment while it's still clear in his mind, and he figures out, the answer to the question. And what he did, the experiment that he did, is he took a heart. I can't remember what kind of heart it was, if it was like a frog heart or something. And here's the vagus nerve attached to it, and I don't know exactly what this experiment looked like, but so they stimulated the vagus nerve and watched that the heart did in fact slow down, and that heart was in a physiological solution. Then they took that fluid, they called it the vagus stuff, and they put it to a new heart, and the heart still slowed down. And this heart was not innervated. They didn't stimulate the vagus nerve. So whatever the chemical it was the vagus nerve was releasing into this solution, it also exerted its same effect on the heart. And they concluded that then the thing that was causing the heart to slow down was a chemical substance, not an electrical substance. That discovery landed him the Nobel Prize. And so it just goes to show you, sometimes some of the best discoveries can come while you're sleeping. It can come in your dreams. Kind of an interesting story there. Okay, now I think we're going to pause there, and when we come back later, we'll talk a little bit more about the vascular system. We've talked about the cardio part, the heart, and then we'll talk more about what is downstream of the heart, the different vessels and such.